Do you hear me?
Yes, sir. Yes.
Yes, Rev, we can
I
hear
don't
you.
know why I'm not hearing you. Carol, I'm,
Can you hear me now?
Testing, testing.
We can hear you.
Yeah, we can hear you.
Can you hear me?
where?
Where's the sound? Yes. Okay. All right, can everybody hear now?
We can hear
Yes.
you?
Yeah,
Can
yeah.
you hear me?
So
Can you
they're
hear
saying
me?
yes, so
Can you hear me?
testing.
Yeah, we can hear you.
I hear
Okay,
you
now
now.
we can hear
Yes,
you.
all right.
Can you hear me? Okay.
Yes.
Yeah,
Reverend Sharpton, good
Don't
evening.
worry, Congresswoman. They've been trying to mute me all my life, so welcome.
Nobody can mute your voice, sir.
So Congresswoman, why don't you start us off?
Oh, I'd be happy to, sir. I'll be happy to. So give me a minute. So thank you for having me, Reverend Sharpton. I am honored to be on this panel. I'm Congressman Shri Thanedar, and I'm proudly serving Michigan's 13th congressional district, including the city of Detroit. And
Wow.
I'm honored to
Well,
participate in this important panel discussion on healthcare access and affordability issues affecting communities of color across America. I represent a city that is 78% African American. Today, we are specifically addressing the 340B drug discount program and ensuring that the savings from this program reach the patients who need it most. The 340B program was created by Congress to help hospitals and other healthcare providers serving low-income and uninsured patients obtain affordable prescription drugs. However, recent reports have uncovered that some hospitals are not using these savings as intended. Instead, these institutions are using the discounts for their own bottom line instead of passing them on to their patients who are in dire need of assistance. This misallocation of funds is unacceptable and a direct violation of the congressional intent of the 340B program. Last year, in the city of Richmond, we saw firsthand the devastating impact of hospitals not using these savings to make healthcare more affordable for their residents. Patients in need were forced to pay full price for their medications while the hospitals benefited from the 340B program. This must not continue, and we need to hold hospitals accountable for the way they allocate these funds. It is the responsibility of the Biden administration and Congress to provide robust oversight of the 340B program to ensure that the intended help is reached those who need it most. This can only happen if hospitals and other entities benefiting from the program are transparent about how they allocate their drug discount savings. As we discuss these critical issues, I urge all of us to keep in mind the vulnerable communities that are disproportionately affected by the lack of access to affordable health care. It is crucial to acknowledge that everyone, regardless of their background or status, deserves fair access to affordable and high quality health care.
Well, thank you for that. Colleen Meeman is on. And Colleen, I'm going to ask you to pick up and moderate the discussion. And I know we have Delegate Kathy Tran on. I know we have Delegate Delegate Tran is from the Virginia House of Delegates. We also have Delegate Marcia Simone, CIA Price. We also have Attorney Keys. We have Bishop Dean Nelson of the Frederick Douglass Foundation. We have Reverend Nelson Rivers of Charity Missionary Baptist Church in North Charleston, South Carolina, and the Vice President of Religious Affairs for National Action Network, and there may be others. But let me pass on, and of course, Carol Wallace is here with us, here that runs our projects here at National Action Network National. So Colleen, why don't you take over and we will be guided here a few remarks from the panel.
Great, thank you. And I'd like to thank you, Reverend, for the honor to be among such esteemed company today, and particularly people who share the goal of ensuring access to high quality healthcare for everyone, regardless of where you live, your ethnicity, your ability to pay, etc. The goal of today's session, as I understand it, is to think about what is the solution? What is it that the people who share this common goal should be advocating for moving forward to make this program work in a way that actually does benefit underserved individuals, medically underserved individuals? I think we're all familiar with, for instance, the Bon Secours article and how this program is being used by some players in the 340B space simply to boost their own profits, apparently much more so than to actually care for underserved patients. Before I turn it over, I was going to turn it over to Delegate Tran to talk about her efforts in the Virginia State Legislature. Given what a confusing, complex program it is, I thought I would start with a very brief review of how 340B is supposed to work. And by way of background, I worked on this program both in the Federal Department of Health and Human Services, and I've worked for a long time with community health centers. So I've seen the program from both sides. The idea is that a drug manufacturer, if they want to be able to sell their drugs under Medicare or Medicaid, they have to be willing to sell those drugs at a discount to certain, and I'm going to put this in quotes, safety net providers. And these safety net providers they're listed out, the types of providers in the statute. The idea then is if you're one of these safety net providers, you're supposed to be serving a disproportionate share of medically underserved individuals. Then if you purchase this drug at a discount, then when you provide this drug to an underserved individual, the cost should be lower for your health center or your provider. So I use a simple example of, let's say there's a drug where the regular price is $100 and the 340B price is $70. But your patients, say at a community health center, you know they can only afford $20. But then you purchase it under 340B, you sell it to them for $20. And as a result, you've only lost $50, the difference between that $50 and that $70 that you paid and the $20 the individual paid. On the flip side, then, when you have a patient who has insurance, be it Medicaid, Medicare, private insurance, the idea is that you're supposed to be able to purchase that drug for $70, but get reimbursed the standard $100, which brings in savings of $30 in that case. Those savings are to be used, according to the congressional intent, to help support the cost for, say, providing the drug at a discount to the uninsured individual, and also to support a whole bunch of other services for the underserved populations. And the concern is that some providers are bringing in much, much more in savings than they're actually reinvesting into their underserved populations. And that was I would say, the crux of the article that came out about Bon Secours. So with that, I'm going to turn it over to Delegate Tran, who is a member of the Virginia State Delegation, to talk about her work in this area.
Colleen, thank you so much. And Reverend Sharpton, I'm honored to join you this afternoon for a really important discussion about the fact that healthcare is a human right and making sure that we're expanding affordable, high-quality healthcare is a priority for all of us. When I read the New York Times expose this September, I remember it was a Saturday morning, I was really infuriated by the accounts of taking away resources intended for the East End community in Richmond. It is a predominantly Black community and also a low wealth community, that the hospital would take those resources intended to expand healthcare and frankly, put them in wealthier, wider suburbs and other parts of the city. And so what I realized, in talking to some of our advocates and community leaders is that we had a whole host of other hospital systems in Virginia that also participate in 340B. And some of those hospital systems have voluntarily agreed to the American Hospital Association's 340B good stewardship principles, which are pretty simple: a commitment to communicate the value of the 340B program publicly, disclose their estimated savings, and then continue to perform a rigorous internal review. And so we worked together to draft House Bill 2472 based on those principles by the American Hospital Association. And basically it's to say that if there's some hospitals in Virginia who are voluntarily adhering to these principles, doing that type of analysis and reporting and having that level of transparency and internal review, then that must also be a good standard at a minimum for all the hospitals in Virginia that are participating in this program. I had some colleagues, even today before our call this afternoon, who say, hey, this is a federal program and it's complex and we don't have a role at the state level. And I really, respectfully disagree. Despite where the authorization for a particular program may come from at the federal or state or local level, we know that when you have underserved communities and people, that those additional barriers and poor health outcomes come to rest on the shoulders of our state and local governments to then have to make sure that we are providing adequate care. And so I think that there is a role for the state government to then say, absent federal action, we want to know what's happening. These are happening to people here in the Commonwealth, to Virginians who deserve to have these funds reinvested into their community. It is the intent of the federal program. And so we're going to hold you accountable. I had also others throughout this process who said, hey, we're actually doing a good job. And, so if you are doing a good job, then you should have no cause to worry for sharing your story publicly. And in fact, it actually might spark some additional dialogue amongst a hospital system and the local community to say, is this actually how those funds are best reinvested into the community to support those community members? And maybe there might be some additional positive steps that can take place from there. And unfortunately, our bill did not pass the session. We had, one hospital named in that expose, Bon Secours, who stood up vocally against this bill. All the other hospitals, the Virginia Hospital Association itself, remained on the sidelines. And I thought that was just a really interesting decision by the other participating hospitals. But we just had one who spoke out against it. And I'm hopeful that we'll be able to continue this conversation at the legislative level. I do know that the conversations between the hospital system and our community advocates and leaders are taking place. And so hopefully that the New York Times article and the legislation I put forward this year help to continue and support that level of dialogue.
Delegate Tran, could you tell us a little bit about what Bon Secours' response was? And by the way, if it would be helpful for us to explain a little bit more about the Bon Secours article, please just let us know. We'd be happy to do that. But could you explain how they responded?
Sure.
And how they justified opposing your bill?
Yeah, Colleen, it might be helpful if you wanted to just kind of give that summary of the New York Times article.
Sure,
I pulled out some examples as well, but go ahead.
No problem. This is a rather simplified summary of the bill, but Bon Secours is a hospital system based in Richmond. They've got places all over the country, and they have, say, about half a dozen hospitals in the Richmond area. 5 of them tend to be in majority white areas, places of higher income. And then relatively recently, they purchased Richmond Community Hospital. Richmond Community Hospital was founded by a group of Black doctors during the era where Black patients were not welcome at the white hospitals. So you have about 6 hospitals in this system now. And the hospitals, the other hospitals, not Richmond Community, all have outpatient clinics associated with them. But the way the 340B rules work, and this is all in federal law, it's not something the agency has control over. The Bon Secours was able to take all of the outpatient clinics associated with all of those hospitals in predominantly higher income, better insured areas and make them officially 340B eligible by putting them organizationally underneath Richmond Community. As a result, they brought in over the course of a decade, roughly $1 billion, billion with a B, in 340B savings from the outpatient clinics around in these more well-off areas. What was the most
Is that 1 billion in profit?
That is 1 billion in savings. For instance,
Wow.
in my example, you paid 100, the regular price for a drug is 100 and you only paid 70, that would be $30. Well, it takes a lot of those drugs to make make $1 billion over a decade, but they did. In the meantime, however, they did not invest those savings into the Richmond community, either the hospital or the community that it served. Instead, over that time period, services were consistently removed from that hospital and from that community, to the point that when the article was written, the hospital consisted of nothing more than an emergency room and a pharmacy. There were no specialists, there was no inpatient, there was no ICU, there were no outpatient clinics near there. There was a building across the street that was supposed to house specialty services, but they just never seemed to get around to finishing it. And Bon Secours' response was, well, we invested $8 million in that community, to which everyone else says, but 8 million out of 1 billion? Of course, as soon as this came to light, Bon Secours is putting more effort into that community. But the other piece that was just very difficult to read was that Bon Secours claimed, well, if you have an emergency case at Richmond Community, you can just send them to one of these other hospitals and we'll take care of them there. Well, there were a lot of stories of individuals who didn't get to the other hospitals in time, who had to wait with very serious health outcomes as a result. So it was a very difficult and upsetting article to read.
It was really hard. And I think there were some very specific examples of patients who had really poor outcomes as a result of not being able to access care right in their community, right? They were waiting for very long periods to be transferred by ambulance to another, system hospital. People who, whose heart had permanent damage because they weren't able to get immediate care for signs of a heart attack. I mean, I think, and people who passed away as a result of that. I think that in my conversations with the hospital and with other hospitals, as we were talking about this bill, I said, we all should want for Richmond Community Hospital to be a hospital that we ourselves would want to go to. And I think that's the level of care. And if we think about it, so it's not just somebody else's community, but would I want to go there? And actually this year I stayed very close to Richmond Community Hospital during my time in the legislative session. And, is it a place that you would want to go to as an individual, as somebody who's coming to lobby on behalf of the hospital? And I think we all agree that's the goal. And so let's just make sure that there's transparency and accountability in getting there with a program that's intended to reinvest directly. I think, Colleen, the way you spoke about kind of organizationally, what you're able to count as part of the 340B program, if you have multiple, if you have a large system with multiple sites, I think is key to this, because if we're able to narrow that down to that specific hospital, that specific location, so that you're not able to spread the savings into other associated hospitals or clinics, I think might be something interesting to explore. But I think what Bon Secours was saying, back to your question, just actually pulled up the the testimony from our bill hearings is that essentially their claim is that they do reinvest the savings into the larger community. And if you look across, all of how they've done that, that is helpful to Richmond as a whole. And so I think kind of making sure that definition of community is also tightened is really important.
Now, is there somebody here, Nick, I'm going to look to you. Nick Widmyer is with the National Association of Community Health Centers, but until recently was involved, was on Capitol Hill. Nick, can you talk a little bit about the view on this program from Congress?
Sure. Thank you, Colleen. And thank you, Reverend Sharpton, for convening this panel. I'm very excited to be here. And thank you so much for your interest in and your leadership on 340B issues. My name is Nick Widmyer. I'm the Director of Federal Affairs for the National Association of Community Health Centers. There are about 1,400 community health centers in the country, and we provide care to 30 million patients, mostly uninsured or underinsured. About 90% of our patients make less than 200% of the federal poverty line. So this is an issue. Providing care to underserved communities is central to NAC, that's my association, and all community health centers' mission. I'd say thinking about 340B and the health centers, 340B is huge for all of NAC's members and the community health centers. And our funding has been flat for years. And as our funding has been flat, the discounts that we receive through the 340B program have become more and more important to our mission, to letting our members complete their mission of serving communities. And I'll get into kind of the federal thing because we do have some announcements there, but I just wanted to share maybe a bit of a story about how our members use the 340B program that I think will be a good contrast. And this is a story from a pharmacist. We, the pharmacist, had a patient who was receiving chemotherapy from Sam's Club because it was the cheapest that she could find. The patient was paying $350 from the pharmacy. And even then, she wasn't able to take it on a regular basis because of the cost. After speaking with the patient, we were able to get her chemotherapy through 340B, and the cost went from $350 a month to $3 a month. The patient was overjoyed and to the point of tears because she had been going without her medication, and she didn't know how long she would be able to live if that continued. So I think I share that anecdote to show that NAC members, the community health centers and the community health center program, we are good stewards of the 340B program. We use those 340B discounts and the dollars that we're able to get for them in a way that is consistent with what Congress intended when it created the program back in 1992. With that said, we have nothing to hide. We are supportive of bringing more transparency and more accountability to the 340B statute. Over the past 5-6 years, the 340B program for our members has been severely undercut by pharmaceutical companies that have not complied with their with shipping discounted drugs to our pharmacies. And it's been undercut by pharmacy benefit managers or PBMs that use contracting methods to steal the benefit from us. And it's time for us to sit down, work with any stakeholders to improve the program and make sure that it's serving the purpose that Congress intended when it created the program. So last week, we're willing to work with anybody on it. And last week we announced a partnership with, of all people, pharma, the pharmaceutical company, trade organization that I think is very famous in Washington, to develop a legislative proposal to protect the program's integrity, address the issue of pharmaceutical companies refusing to ship to covered to honor 340B pricing at community health centers, pharmacies, and protect the program from these predatory pharmacy benefit managers. So this is really kind of a pairing of odd bedfellows. When we go to the Hill over the next few weeks, I think quite a few people are going to be surprised that the community health centers have been able to reach kind of a tentative agreement with Big Pharma, literally, on protecting the 340B program. But we are committed to working with anybody and everybody to protect this program because of how important it is to our members. And Congressman, thank you so much for your interest. I'd love to follow up with you and your members about kind of our Hill strategy here, because quite frankly, I just want to emphasize this, and this is the message that I'm sending to the Hill for our health centers, reform of the 340B program, protecting the 340B program. It's something that cannot wait. Or, we won't be able to complete our mission of serving communities in need, which is, why I think the folks at the health centers go to work every day. So
Nick,
I'm happy to answer any questions about that, but that's kind of my pitch ahead of this meeting.
So Nick, it sounds like you're drawing a distinction between how the Bon Secours hospitals of the world use their 340B savings and how, say, community health centers do. I'm curious if other people here have had other experiences with 340B in your own communities and what they have been like, if you found it to be a useful program, if you feel that it is being abused in the way that, for instance, the Bon Secours example. So, Dr. Udo, I believe you're speaking, but you're on mute.
Hi, can you hear
There
me?
you go. Yes,
Hi.
that's better. Thank you.
Good afternoon, everyone. My name is Ifoma Udo. I'm from the Black Women's Health Imperative. I am the new Executive Vice President for Policy Advocacy and Science there. Today is day 14 for me. I'm excited. Thank you for this invite. A little bit about the Black Women's Health Imperative. We are a national organization that is centered and focused on the health equity of Black women and girls. We've been around for 40 years. This is our 40th anniversary year. We're really excited to be celebrating that this year. Your specific question around other examples that we've seen specifically in certain communities, I want to talk a little bit about the examples that we've seen specifically around HIV. And I really appreciate Nick's point around wanting to partner specifically with pharma and partner specifically around sort of thinking about how we can better improve those relationships in that space. We've seen a lot of discrepancies, particularly in the last year, around access to HIV prevention tools such as PrEP and PEP. Those are two that are sort of been on the chopping blocks, very quite honestly, in specific communities. And as we know, the rates of infection for African Americans in this country are incredibly high in terms of particular communities, and specifically Black women, and specifically Black women in the South. And so being able to talk about how the savings, quite honestly, that is coming from the use of the mandate around 340B pharmacies is incredibly important in terms of how that money gets put back into community, right? Because we are seeing it and we've noted it and we've watched it for the last 30 years since this mandate has been in place in 1992, specifically for HIV. Delegate Tran pointed out a couple of notes that I thought were really interesting in terms of the things that we should do going forward around maximizing the use of the potential of the 340B pharmacies. And she noted specific things, being transparent, and I think we've heard other people say this, being transparent about the savings and the disclosure of savings, reviewing and monitoring what's happening, and thinking about where the savings have gone. In a recent Health Affairs article, we're talking specifically about the situation in Virginia, but this is a national situation, right? And so since in 2020, the participating sites who were accessing the services from 340B pharmacies went up from 8,000 in the United States to 50,000. We know that that increase occurred as a result of what was going on with COVID and the need to access the savings that were coming out of drug use and pharmaceutical use during COVID. That increase also spawned $30 billion of savings across the nation. So we're talking about the $1 billion.
Try to mute that. Go ahead, that should help.
Sorry about that. We're talking about the $1 billion that we saw in the New York Times article, specifically in Virginia. But if you look at what happened nationally, there were $38 billion of savings that occurred in that time period as a result of the use of the 340B. And so then the question is what happened to that money? And so I would also argue that one of the other points that we need to add to Delegate Tran's eloquently pointed notes about what we do is that we also not only need to disclose these savings so that everybody knows that these savings are happening, we need to review routinely what's happening, and then we need to allocate. We need to allocate these savings specifically to programs that are going to be to the benefit of the wellness and the health equity of Black women, Black people, BIPOC communities, Native American communities, federally qualified health centers, all of the things that Nick just spoke about in terms of how do qualified health centers access being able to set up mental health programs, wellness programs, doula support programs for maternal child health. We need to allocate. Once we know where that money is, then our specific task is to actually allocate that money towards programs. And so I wanted to be able to add that point specifically in terms of recommendations going forward around what happens with 340B pharmacy work. So I'll stop there.
Do other people have experiences in their communities that you would like to share about how 340B is or is not working well? Okay, please just jump in. In the meantime, I would just state as a former federal employee who worked on this program, there is nothing in the 340B statute that requires that the savings be used to help underserved populations. It is honestly, in the 30 years I have been doing public or healthcare policy work, it is the worst written statute I have ever encountered. There is no requirement whatsoever that the savings be used for anything in particular. What does help is that when you're talking about groups that get federal grants, say Ryan White Clinic, say community health centers, hemophilia, those groups are required by the terms of their grants to invest the savings into activities that expand access, but that is not the case for hospitals. They have no such requirements. Bishop Nelson?
Thank you so much. Just want to say thank you to Reverend Sharpton for the opportunity to be on. I see that we have a number of our leaders from around the country, in particular, our president from Virginia. I serve as the chairman for the Frederick Douglass Foundation. Our tagline is righteousness, justice, liberty, and virtue. As Reverend Sharpton knows, we've done a few things together in the past. We tend to come from a center-right position, but I love hearing what I've heard today in terms of how we can work together. We believe in the free market system, but we do not believe that when government programs are misused and they're particularly designed to help people in certain communities and it is abused or perverted by industries, that's wrong. And we look forward to seeing how we can work together with some of our legislative friends on Capitol Hill, as well as in some of these states. I do have a couple of questions that I would like to direct towards Delegate Tran. I lived in Richmond, Virginia for many years. Our organization has opened up the East End Pregnancy Test and Help Clinic that is there to provide help for women who find themselves in unplanned pregnancies. And we have a lot of advocates and pastors in the East End. I'm curious, Delegate Tran, what were some of the reasons or arguments that your Republican colleagues used as to why they did not support what to me seems to be very common sense?
Sir, I would just say that, sometimes you work long and hard on legislation and you come up for your hearing. Sometimes you get, a short period to present, and there were no questions from my Republican colleagues. It would probably be safe to say I wasn't sure that this bill had an opportunity to pass out of the House of Delegates. We have a Republican majority in the House, but I thought it was important to have a public conversation about the need. And I just want to clarify, I don't live in Richmond. I represent parts of Northern Virginia.
Northern Virginia,
County.
yes, ma'am.
But I was really, just moved by what was happening to ACT and working very closely with some of the advocates and community leaders there. So I would also connect you to the I want to make sure I get the name right. It's the Richmond Coalition for Health Equity that's been working in the East End on these issues, along with the Interfaith Center for Public Policy, the Virginia Poverty Law Center, and the Commonwealth Institute for Fiscal Analysis, have been really kind of spearheading some of the work and lifting up the conversations. But unfortunately, we did not have a robust dialogue on this issue. It was my testimony, the testimony from our community advocates and leaders, which really highlight some of the issues we talked today about the need for care, the poor health outcomes that affect members of that community directly. And we just want to know what's going on. And nobody should be afraid about transparency. And then the testimony from Bon Secours.
Let me say this, colleague, after Tran's statement, that's exactly where I am. And in fact, at National Action Network's National Convention, Dean Nelson, we're going to continue this because the troubling thing, and I know you said you're right of center on many issues. I'm probably left of center on many issues, but I think that this affects everybody. If you are having people abuse government funds that should be reinvested, this is not a right wing or left wing issue. And anyone that would be opposed to looking into this, and like I said, at National Action Network's convention, April 12th to the 15th, they want to have another roundtable on this and pursue this. But anyone that does not want to look into this, you'd have to question what is their motive and why anyone would not want to pursue this and make this a national issue. I'm going to have 9 of Biden's cabinet secretaries at our convention. I want to know why this is going on unexplained. And the Congresswoman didn't create this issue. You didn't create it, Tran. New York Times came with this, and here we are, how many weeks later before we're starting to have a discussion on this? This is crazy. So that's why some of us said, well, if nobody else is going to pick this up, Colleen, we will, because it was like in a weekend New York Times, and it's like it didn't matter. And I think it does matter that these funds are not being reinvested. And if they are, then we need to know how and why.
Absolutely. And if I could, go ahead, sorry.
I wanted to add, I think as you're building out your coalition also for the congressman and for you, Reverend Sharpton, some of these hospitals serve rural communities too, right? So that these, and you can, so I think it's a very broad, diverse coalition that could be built around lifting up the need to make sure we're reinvesting in those communities, because some of the rural communities are.
Well, I'll send Brother Nelson out to the rural communities.
Happy to go. That's where I grew up, sir. That's where I grew up. I would like to ask Colleen, are there pockets in the country where we've identified that this is more prevalent than others? Just trying to get when we think about addressing it at the federal level, I'm trying to think of which targeted members we should look at based on maybe where this is taking place.
Yeah, well, I can address that if I can, Colleen.
Absolutely.
So Reverend Sharpton, this is a great discussion, and thank you for doing that. But we need a follow-up in terms of what can Congress do, especially the Energy and Commerce. So the chair and the ranking member need to be involved in this. There need to be a better oversight. There's no doubt about it. And we need to build that as Congress. We need to build that because, robbing the underserved Black and brown communities is just not acceptable. And, not only we need to prosecute, we need to hold these bad actors accountable, because that's just not, acceptable. But we need to make sure that we build in robust oversight, and that can only be done through the Energy and Commerce. So we need to get them involved in another discussion like this.
Well, I think, Congresswoman, that if we could get an even smaller working group on this, and I'd be willing to come to Washington with them and maybe go visit the chairman of those committees and put pressure on them to convene and deal with this. I don't think we need to just have a rhetorical session or two and not go forward and challenge the Congress itself to do something about it.
Right, Reverend. Absolutely. And perhaps a committee hearing on this issue and a public hearing where people, you, Reverend, and others should come and speak before the committee. We need a better oversight.
Yeah.
Reverend Sharpton and everyone, one point that you got into about the rural areas. Reverend Sharpton, first, thank you, Reverend Sharpton and Cara and all of you. But thanks for the education. A big part of this is one element that can be very helpful, has not been talked about much, is a Black church. Much of what we're dealing with are Black folk, and the Black church and underserved communities mean us. Back at the beginning of the pandemic, my foundation and my church started something called the Movement. It was an acronym for testing healthcare equity to move us, bringing testing to our communities to save lives. But we found out that there are multiple counties in my state that have no hospital, none. The federally qualified healthcare centers are critically important because they fill this role. And our challenge, frankly, with the Barnes and Coors Hospital, was Roper, St. Francis, the Medical University. My staff, my team was able to pull together 6 of the congressional districts in my state have these 340B hospitals. Of that number, the majority in Jim Clyburn's district, where I am. And in that number, we find that there are many hospitals that we have bad relationships with anyway. Wow. So our opportunity now is to deal with them on, they tell us they can't do it. They would not provide the resources without pressure. And we were able to bring a lot of pressure, but we found out that they look at the federal health centers as enemies of them, when the fact is the matter, they fill a big gap. So for us, the Black church, and speaking about having done this now with these hospitals for the last 3 years, the data is very important. The education is even more important. And now that we know, frankly, we can go ask the question, where'd the money go? You told us you couldn't do these things. My church is running a van up and down the road covering about 18 counties, doing about 300 miles to go make sure healthcare testing was done. And we're taking the federally qualified healthcare centers to provide what the hospital should have been doing. And then we find out that the resources are not there and they're crying broke, but we found out they got the money from this program that frankly myself didn't have time to know about or find out about. So thanks to Reverend Sharpton and Cara and all of you, because now 340 can be added to the toolkit of things that the Black community can do through its churches. Because I can promise you, as one of the leading officials of our local association, we'll be talking about this because I got 2 calls this week from Black doctors who are having a problem with a Barnes and Coors hospital. They're accusing them of being racist about who decides, because they found out that a lot of our community trust Black doctors. And I thought it was just my imagination, but now it turns out that Black doctors being moved out and replaced by white doctors because the money comes following the patients. And so if you decide to follow, if you want to get a Black doctor, they're now running the best cardiologist in our area, according to many testimonies, is a Black doctor. He called yesterday about he's having a problem at Barnes and Coors Hospital. A part of this is about where the money is. And so thank you for this. This is very helpful. We'll be doing it. I'll be talking to Reverend Sharpton more about this based on the calls I've just gotten in the last 2 days. And as things happen in our community, when folk find out that somebody will help, then all of a sudden, what was silent becomes very loud. Now people are telling me this has been going on for a good while. So 340 is a way for us to find out where the money goes. We have a list of all the hospitals in the state that participates, and the ones in my area are very important because we know each and every one of them. And most of them we don't have good relationships with. but maybe with the pressure, we can have a much better relationship, and even more importantly, a much better outcome for our community. So thanks a lot. We'll be looking at this even more. Thanks for the invitation, opportunity, and the education, because who knew that they could make this much money, put it where they want to, and no one call them out on that. So thank you for calling them out. And
Well, I think that, Colleen, and I know I'm looking at the clock. I know we started, but many of us have other things.
Right.
We're going to follow up at NAN's conference, but I think if we can get a smaller working group, I think Nick has put in the chat where people can get some more information. And the congressman, I'm going to call you and Delegate Tran. I made you Congresswoman Tran, but you is Congressman and Congress and Delegate. I think if we get a small working group to follow up, I'm committed, Colleen, to make this until we get real answers. Again, I'm agnostic on this. I'm not saying either way is right, but I know something is missing and we need to know where it is.
Absolutely. And if I can just wrap up by responding to Bishop Nelson's comment, it's not that there's a particular part of the country where the unethical but not illegal behavior like bon secours is happening more. It's more about the particular type of provider. The most common stories we hear of abuse or unethical use of the program is in nonprofit, what they call DSH hospitals, disproportionate share hospitals. They are around the country. That's why, believe it or not, some of the good actors are actually teaming up with the pharmaceutical manufacturers, which we know is sort of strange bedfellows. But these sorts of abuses, we have reason to believe, are happening all over the country. So I very much look forward to an opportunity to discuss this issue further. I thank everybody for their interest. 340B has such potential to be a benefit for medically underserved communities. But the way it's structured right now, for many hospitals, that does not appear to be the case.
All right. Well, thank you, everybody, for your time, and we will be following up. Thank you.
thank you all.
Thank you, Reverend.
Thank you.